I'm Dr. Laura Hungerford. I'm the Department Head of Population Health Sciences and the leader of the Virginia Tech Public Health Program. I'm also an infectious disease epidemiologist and veterinarian. Welcome to the Virginia Tech Public Health Program. Congratulations on your acceptance into the Bachelor of Science in Public Health. We are proud and excited to have you join us this fall and to also join us at the Virginia Tech, Virginia Maryland College of Veterinary Medicine, which is the home college for the BSPH. Every day we see and hear how your new major, public health, is responding to COVID and helping our local communities and people worldwide. Our current students, faculty, staff, and alumni are playing key roles in pandemic response, and we look forward to the ways that many of you will also help. But the host of other problems we work on in public health haven't gone away, including racism, cancer, other chronic diseases, zoonoses, injury, and nutrition. We know you bring your own experiences and ideas of ways to make the health of the world better. We're excited to have you trying out your ideas as you learn them through engagement with real communities. Learning by experience is something you'll do a lot in our major and is a central part of public health. And we hope that you apply what you learn here in Appalachia, in your hometown, and through study abroad opportunities worldwide. We've designed the BSPH specifically so that you can combine it with other majors and minors to customize your academic program to match the unique skills that you'll need to meet your career aspirations. Your creativity and innovation will improve future population health in ways that you invent, not just for infectious diseases like COVID, but for all the threats that shorten our lives, threaten the animals and environment around us, and disproportionately affect underserved populations. Virginia Tech's motto, Ut Prosim, focuses on our commitment to serving others, but in a way that transforms the future. We're so excited to have you join us to help build on our public health framework with new ideas that will transform the future health of those we serve. So, again, welcome, and let's get started.
Hi, my name is Leah Doth. I'm a junior public health major from Virginia Beach, Virginia.
Hi guys, my name is Abigail Donahue, and I'm a junior majoring in public health from Culpeper, Virginia.
Congratulations on your acceptance to Virginia Tech. Class of 2025, we are so excited to welcome you to the public health major. I chose public health because I wanted a hands-on major that would combine my fascination with science with my love for talking and working with people. One of my favorite experiences during my collegiate career as a public health major has been the Appalachian Community Research course. In this course, there was about 4 faculty members and there was only 11 students, so we really got that one-on-one connection with the professors. During this course, we got to research recovery to work in the New River Valley, so we interviewed students with substance use disorder as well as employers that work with people with substance use disorder. This provided me such a hands-on experience, and I'm so thankful for it. And we presented our research at the Appalachian Regional Commission Conference in Washington, D.C. So even though this has been such a troublesome time for COVID for everyone, it has affected everyone in some form or fashion, COVID has actually given me so many opportunities to get hands-on work in the public health field. I was able to become a COVID crusher, and through that we go downtown on the weekends and we hand out face masks and hand sanitizer, and we also have trivia for students to play, and we give also masks to local businesses. And currently with that, I'm doing testing in the New River Valley for the health district, and I'm also working on a food drive now for Virginia Tech students as well as people in the New River Valley.
So I wanted to go to Virginia Tech my whole life, so the decision wasn't really hard for me, but definitely being on campus was even better than I thought it was going to be. So I come from a family of Hokies. I wanted to be a Hokie all my life, so the decision was pretty easy for me. But being on campus, I was really able to experience the unmatched school spirit that's here at Virginia Tech. It's truly amazing to be surrounded by other like-minded individuals who love this school as much as I do. As a freshman, I did not come in as a public health major. I actually came in as a microbiology major. But I always just felt like I was kind of floating through. I really hadn't found my place yet. I took a public health elective early on in my college career and fell in love with it. So I instantly changed my major, and this has been my home ever since. So my favorite part about the public health program is the diversity of the topics that we get to learn about. So it ranges from more science-based things like epidemiology and biostatistics to more social science like sociology, behavioral theory of health promotion, and psychology. So it's a really good combination of the hard science with the social science. When the coronavirus lockdown started in March of 2020, I joined the Virginia Medical Reserve Corps, which is one of the public health volunteering organizations that helps serve the state of Virginia. And through that, I was able to gain employment with the Virginia Department of Health as a state contractor, as a case investigator. So day to day, I call positive coronavirus cases to conduct interviews with them, and then further do contact tracing. And then I help provide them with resources and their isolation guidelines to help keep the community safe. Come on, it's time for Dr. Redican's class.
Hello, I'm Kerry Redican, Professor of Public Health in the Department of Population Health Sciences at Virginia Tech. And we're in the College of Veterinary Medicine, but we're the human side in Population Health Sciences. And I teach the first public health course for undergraduate students, Intro to Public Health, which is Population Health Sciences 2004. And what I'm going to do right now is give you a sample of what a typical lecture would be in that class. And we're going to focus on the COVID-19 virus, something that's all on our minds and hearts and so forth over the last few months. To do that, I think what we're going to do first is go ahead and set up a little bit of a context here with a quick review that we would normally have in class. And when we talk about diseases in class, we talk about them as infectious or chronic. And infectious diseases are diseases that are caused by a pathogen. This is basically, these are microorganisms like bacteria, viruses, rickettsia, helminths, and so forth. You'll learn a lot about those and the diseases and the epidemiology of those diseases, when you take the course and so forth. But that's what we talk about, those caused by a pathogen. And with infectious diseases, usually we have a quick onset, meaning in some cases hours in the cases of food poisoning to sometimes days and weeks after exposure to the pathogen before we have an onset of clinical symptoms. So that's what we mean by quick onset. And then quick recovery. Normally we have an acute phase where we really get sick, but then after that we feel a little bit better, a little bit better, a little bit better, and then we wind up recovering. Unfortunately, for many people with COVID-19, that hasn't been the case, and I'll explain why here shortly. Now, one of the things common to all infectious diseases is this links in the chain, okay? And you can see the infectious agent there, or the pathogen, such as the bacteria, the virus, and so forth. And these are living organisms, and those living organisms have to live somewhere. And the fancy word they mentioned, or the fancy word we use, I should say, to identify where the home of that pathogen is, the home of the infectious agent, is called a reservoir. Now, from that reservoir, we need a portal of exit, a way for that pathogen to get out of the reservoir. And then we need a means of transmission, right, before it can infect somebody. And then we need a portal of entry to get into somebody's body before they'll have an infection. And we call that person a susceptible host. If we are going to have disease spread through society, like a COVID-19, all of these links have to be connected. If any one link in this chain is broken, we're going to basically reduce the spread, if not eliminate the spread of that disease. So it's critically important to think about these links in the chain in terms of COVID-19 and literally any infectious disease. Okay, after a person is challenged with a particular organism, there's a number of stages to any given infection. Again, regardless of the disease, these stages are commonly called incubation. That's the time period between exposure to the pathogen, the organism, and the onset of clinical symptoms. There's the early signs of a disease, or the early symptoms. We call this the prodromal stage. Those are the early signs. And you probably have noticed, if you've ever gotten sick with the flu, that let's say you really are sick on Friday, but then you think back, come to think of it, on Wednesday, I wasn't feeling that well, right? I had a scratchy throat, a little bit of a headache. You may have thought it was because of allergies or something like that, self-limiting albeit, but nonetheless, those may have been the early signs of that particular infection. The acute stage is when a person is at their sickest. This is when they're just sick, high temperature, chills, all these kinds of things. That's the acute stage. Then after the acute stage, most of the time we go into recovery, where we recover from that pathogen. Our immune response system deals with it, or immune response system plus medications and so forth will deal with it. So back to our chain, okay, our links in the chain. What are some of the things that can be done? And we're going to highlight this more later on, that can break those links. Well, if you wear a cloth face covering, okay, or a face mask that we have consistently been hearing about over the last year, you are breaking a portal of exit, and you're breaking the link for portal of entry, and you're making a ding in this means of transmission, okay? Staying at least 6 feet from other people, you're affecting that means of transmission. Even if that organism does in fact leave that portal of exit, our respiratory system, you're going to be so far away from another individual that in theory it's going to be less likely to challenge them. And then of course frequently washing hands, because we do touch our nose, our mouth, we sneeze and so forth, shedding the organism, particularly viruses, into the hands. And then we shake hands with somebody, they scratch their nose, and that's a means of transmission, okay? So really when we're talking about slowing the spread of COVID-19, right? They talk about wearing face coverings, they talk about washing hands, they talk about staying socially distanced. Really, we're talking about breaking these links in this particular chain to reduce the spread, okay? Very simple concept, and let me click out of this right here. And next slide here, coronaviruses themselves. Most people had not heard of coronaviruses until COVID-19. Well, coronaviruses are a family of viruses identified about 50, 60 years ago. They cause respiratory tract infections like COVID-19, but one of the ones that's most common, obviously, is the common cold. And you probably remember very early on in the infection, people said, oh, COVID virus, that's the common cold. How can this be a problem, right? Well, obviously, there are many different types of coronaviruses, some more lethal, obviously, than others. And the reason it's called corona is because if you look at it, it looks like a crown, okay? Hence the term corona for coronaviruses. And what happens is there are proteins that help this bind to human cells. Now, there are some groups of coronaviruses. 2 groups basically will affect mammals, including bats, pigs, and humans. This is an important concept we're leading to called zoonosis. 1 group affects only birds. 1 group affects birds and mammals, and 7 coronaviruses are known to infect people. So there are many viruses out there, but some of them infect people, others won't. Now, camping onto that, we can talk about coronaviruses from the very simple to the very serious. The cold obviously being very, very simple. The more serious, well, in 2002 you may have heard of SARS, right? The severe acute respiratory syndrome. And that syndrome, coronavirus, had a 10% fatality rate, basically meaning of every 10 people that came down with SARS, 1 died. That's significant, right? Middle East respiratory syndrome, or what we call MERS, primarily was in Saudi Arabia in 2012, very similar, but it had a case fatality rate of 33%. So for every 10 people that came down with MERS, right, you would have 3 people who would in fact die. So you go from very simple to very serious with respect to coronaviruses very, very easily. Now, where the problem comes in with coronaviruses is, we mentioned before, you have a virus that can move from animals to people, right? And so, for example, we thought initially cats were thought to be the animal carrying the SARS virus, right? You have camels were thought to be carrying the MERS virus, hence, Saudi Arabia being the issue there. With respect to COVID-19, you probably heard this, that pangolins, or those scaly anteaters, were the ones that were carrying the coronavirus. Now, if they're carrying the coronavirus, it affects them. But those viruses, given the right circumstances, can jump species, right? So you have cats, that virus jumping species to basically lead to SARS. You have the virus in camels jumping species, right, leading to MERS, camels to humans. Same with pangolins, from pangolins to humans. How does that happen? The environment's got to be just right for that. And we had the perfect storm here with respect to COVID-19. We have a thing called zoonosis, which is going from animals to humans, right? And then we have something called wet markets in parts of the world, and these wet markets are open air markets where there's all kinds of animals that are going in there. Those animals are slaughtered, those animals are infected. Those animals then, as someone's slaughtering them, people can get challenged with exchange of blood products. They can get challenged maybe if it's aerosol and so forth. So there's a wide variety of mechanisms there. But what happens is in the wet markets, a lot of liquids are the result of that. Blood, animal innards, and so forth that could in fact be infected tissue. And a human then would get challenged with it, and then over time, that particular virus could in fact cause that infection in humans. And this is what is thought to have happened with respect to COVID-19. You know, a smaller area of the world, a wet market, all it takes is one of these cases to occur, and then you've got a jump in virus from animals to humans, and then you've got potentially human-to-human spread. And it started off with one, okay, and now we're talking about millions around the globe and so forth, okay? So that's really where it started. As a matter of fact, when you talk about wet markets and COVID-19, the general thoughts in terms of what we think happened is that bats were in fact infected. They transmitted the COVID-19 to pangolins. Then pangolins transmitted COVID-19 to humans in the wet market. And then humans spread COVID-19 to other humans, which is what we're looking at now, obviously, in terms of all the social distancing and masks to prevent that spread from human to human. Okay, COVID-19, basically, we talked about it as being a reservoir, as being in humans. We have it in our bodies, and in fact, we can spread. If we're infected, we can in fact spread that. The portal of exit, applying some of those terms before, is from the human, mouth and nose. So in other words, if we cover our mouth and our nose, right, with a mask, then we're going to reduce the possibility of that spread or that virus from exiting and infecting other people, and even blocking that portal of entry in our mouth and nose. Then the mode of transmission is person to person. So we know that, and at first we didn't know that, and I'll get to that here in a second, all right? Incubation period, about 2 to 14 days. So 2 to 14 days after exposure to the COVID-19, we can expect to come down with clinical symptoms. The prodromal, those early signs of COVID-19 are slight cough, fever, and so forth, right? The acute cough, fever, difficulty breathing, chills, headache, all those kinds of things, the acute stage where it's the worst, all right? And one of the things you hear about is loss of taste or smell that's associated with this virus, which is fairly unique in a way, all right, which is kind of interesting. And some people, if they have some difficulty with taste or smell, they all of a sudden think they're infected with COVID, and it may or may not be true. And then recovery, the good news is most people will recover from COVID, all right? The problem is we have some high-risk groups that we need to talk about that are going to have more difficulty in terms of recovering. And who are those high-risk groups? Over 65 years of age. They're a higher risk group. Over 65, and that's not on their 65th birthday, but again, in the 60s, 70s, 80s, and so forth, you've got usually underlying physical conditions that are occurring, a lesser or more weakened immune response, right? And other conditions potentially, not just with over 65 as part of it, but underlying conditions at any age group, such as diabetes, obesity, immune deficiency disorders, general poor health. So if you really look at society in general, right, you're talking about, a lot of people when you look at over 65 and then underlying conditions and so forth, right? So all of these individuals, if they in fact are challenged with COVID-19 and they go into the clinical stages of this, they are at higher risk, potentially even of dying because of the problems that are associated with COVID-19. Okay, as far as treatment and prevention, all right, the immune system, like with any viral disease, we depend upon our immune systems, and I'm not going to get into the weeds with immunology and that, but we depend upon our immune system to fight off that virus. There are medications to treat the symptoms. It's kind of hit and miss in many ways in terms of that, but there are medications that could be helpful to treat COVID and treat some of the symptoms, but more likely treat the symptoms as opposed to the virus. And now we have, fortunately, 3 vaccines that we can take to prevent COVID, all right? Prevent if in fact we're challenged. Get to that here in a second. Okay, quick history here of COVID, right? Just to get you to the point where we're at. Fall 2019, that's when we thought that COVID was jumping species, right? In these wet markets and so forth, pangolin to human and that. People are dying from COVID-19 in Wuhan primarily. You probably heard that before. But you know, we don't really know why, and it's not necessarily that well publicized, right? So people are dying, who knows, they're dying of a respiratory infection. They don't know what it is, first thing, right? In December of 19, news starts coming out of China of the dangers with COVID-19. Suddenly they're going, there's something more than just a respiratory issue or a flu virus that's out there, right? And Chinese and visitors to Wuhan and other countries begin spreading the COVID-19. So again, probably one person, and then began to spread, primarily initially in Wuhan, and then potentially, because we're so mobile, to other parts. During winter 2019-2020, outbreaks of COVID-19 are occurring globally, and we're hearing this continually in different countries. Europe had a mess with this. Probably a lot of our infections probably came from Europeans who were infected and so forth, okay? Countries started putting in the mechanisms to stop that spread. Again, going back to that chain, right? They're trying to stop the spread. So in trying to stop the spread, decrease that mobility. So suddenly now countries are saying, we don't want people from this country coming because they may be infected and so forth. Testing is not ramped up and all these kinds of things. Again, it's the perfect storm for that. And then sometime in February in the United States, a few deaths were being reported, primarily out in Washington and in California, that are attributed to COVID-19. A handful of deaths, primarily in nursing homes. Nobody's thinking much about this. However, there are some people out there going through the what ifs, thinking we could have a serious problem here, but as of yet, we're not seeing it. Okay, here's what probably got your attention. Winter 2020, about a year ago now, right? The number of cases in the U.S. increases to a point where they're going, we have a pandemic, epidemic, unusual occurrence, pandemic worldwide, okay? Shelter-in-place recommendations are recommended to limit the spread. That's when you probably basically went home to learn for the rest of the semester and so forth, was at about that point, because you really want to keep people sheltered in place. By the end of winter 2020, 1.5 million COVID-19 cases and 100,000 deaths, all right? Now, as far as the U.S., as of March, a year later, right, we have about 28 million, probably over 29 million right now, cases of COVID-19. Total number of deaths about 523,000 or more. Now, I think this morning I looked, I think it was 530 some odd thousand deaths with respect to COVID. Let me set the context here. You've heard of the Spanish flu epidemic, right? Or pandemic back in 1918 that killed 50 to 70 million people worldwide. Of course, the record keeping then is not as good as it is now. So you look at that, the United States estimate for the influenza epidemic that was so terrifying here was 675,000 Americans died, right? So now where are we at? We're up to almost 550,000 probably with respect to COVID-19. By the time this plays out with the variants, we could have more deaths than we did 100 or so years ago from the Spanish flu, okay? So this is serious, okay? There's some things that could have been done to mitigate this earlier, but again, we don't always know this stuff. Now here's where epidemiology comes in, okay, as far as a tool of public health. In epidemiology, we talk about the study of the distribution and occurrence of diseases in populations, okay? Now, you just break that word down. Epi, Greek for upon, demi, Greek for people, ology, study of what is upon the people, right? And so you've got the study of the distribution and occurrence of disease in populations, and with respect to epidemiology, it's a toolbox they have in terms of statistics and other kinds of things that they use to basically try to talk about the distribution and occurrence of disease. 3 questions that epidemiologists must answer, right? What do I think? What do I know? What can I prove? What do I think? What do I know? What can I prove? Now, if you think about those early days of COVID, right? What did they think? Well, they weren't even sure it was transmissible human to human. They weren't even sure about that initially. I mean, it only lasted a week or two, right? But they weren't sure about that initially. But if that's what they think, that it's not transmissible human to human, it's just animals to people, right? In certain contexts, right? It's nothing to worry about. So hence the messaging back in January and early February of 2020 was, well, it's probably not going to be a problem because we have no evidence that there's a spread human to human, okay? So in a sense, right, what the epidemiologists thought was that, okay? Now, that changed. They began to see numbers, they began to get a better idea of this virus, better idea of mobility, better ideas and so forth to say, wait a minute, it's not just that, it's people to people now. So that what they changed what they think, right? And then what do they know? They know they see larger numbers and they see this disease spreading, they see vulnerable populations and so forth. And then what can I prove is the data, the constant data that we see with respect to COVID, who the high-risk groups are, and all these kinds of things. And this has changed, and it changes with any pandemic, any epidemic. What they think initially may not be what they think 2 months down the road. As more data comes in, as more decisions are made that are data-driven, right, they're in a much better position to know more and to prove more. Okay, and you can go back to any pandemic and follow this paradigm right here, and you will see how that changes. And there's been lots and lots of books about these things talking about that. It's not perfect initially. It is an evolving series of answers to questions that will help define what they need to do. Okay, so what are some of the missed opportunities? Why did we get to this point? This is 2019, 2020. Shouldn't we have had a handle on this earlier to stop this, okay? Well, there were some missed opportunities, right? So the first communications out of China was it was a problem but not a big problem, okay? Well, that's a problem. In other words, what we see here is people saying that this is not much of a problem. Well, that's what they thought initially, that it wasn't much of a problem, but it turned out to be a bigger problem. It wasn't until about mid-March that we realized this is a big, serious problem. So if you go back and say what so-and-so said in February and January, that's sort of a zero-sum game because you really can't go back. What they knew at the time, they make decisions based on what they know, right? So after mid-March, all these directives came in and so forth, and people, you know, rightfully so, were saying, wait a minute, you told us we didn't have to wear a mask, now you're telling us we have to wear a mask and so forth. And again, all that goes back to what do I think, what do I know, what can I prove, and how to mitigate that, okay? So there are a number of missed opportunities, and if we could go back and set that clock back and have people shelter in place, you know, and have all the states on board with that and all these things, this course would have gone differently in terms of the numbers and deaths and so forth, okay? So again, a lot will be written about this as time goes on. Okay, as far as COVID-19 prevention, okay, we're at a great point right now because there are 3 vaccinations that are out there that are all highly effective that will in fact, if a person is challenged, they will in fact be able to deal with that virus before having clinical symptoms like all vaccines wind up doing. You got the Pfizer, you got the Moderna, you got the Johnson & Johnson. They're all a bit different, okay, but nonetheless, they're all very, very effective. And right now, our vaccination program in the United States is clicking on all cylinders. We're getting those vaccines out. It really is it's just phenomenal how quickly those vaccines came to market and how quickly they are in fact being administered.
I'm going to pause you for a second just so you know.
Uh-huh.
I don't know if it's on the news today, but AstraZeneca is now available too.
Oh, it is, but it has the lowest of the, 79%. So I don't know how much of that we're going to see.
You don't
That's,
have to mention
yeah,
it. You just,
yeah,
I
yeah.
can't think of language
Yeah,
of like at
yeah,
this time.
yeah. Well, I think the ones that are, but I think that's more in Europe, isn't it, that
I think
they're
they are.
doing that? Yeah. So anyway, I was just,
No
okay.
problem.
Very good.
Just
Okay.
wanted to make sure it was up to date.
Okay, no, that's good. That's a good point. Do you want me to say this or?
You can keep going and
Okay.
maybe mention like this is currently in the United
Okay.
States.
Oh, okay, yeah. So really, currently in the United States, we have the Pfizer, the Moderna, the Johnson & Johnson. Chances are, if you get a vaccine, a COVID vaccine, it's going to be one of these 3. There are other ones, like that's the, what do we call it?
AstraZeneca. You can try AstraZeneca. AstraZeneca.
AstraZeneca,
You
yeah.
also don't have to mention it.
Okay, we have another one that's widely distributed in Europe that doesn't have as high effectiveness as the ones we are here in the United States. Okay. Okay, that's okay, no problem. Other prevention with respect to it. Obviously, social distancing. We're talking about links in the chain. All right, social distancing is very, very important. Sheltering in place or quarantining. We may go back to some of that depending upon how things go with some of the variants and so forth, where there's changes in the virus and they may be able to infect more people than we thought in terms of modeling in that. Washing hands, wiping down surfaces, and face masks. All of these things are very, very important. They're all very, very simple, right? Especially face masks, washing hands, and social distancing. So these are very simple measures that will help limit the spread of the disease. And so we may need to still continue to do some of this depending upon what the data show, all right? Okay, and then we see a lot of information out there with respect to COVID. And there's just tons and tons of information. It's important to kind of take that reflective look on there. New York Times just the other day had a really good article on 14 lessons for the next pandemic, and there will be another pandemic with the way the world is and the mobile and how global and mobilizing we are and so forth. There will be other problems, there's no doubt about that. But what are some lessons? There's 14 of them. I only listed about 7 of them here, and that's the order that they were presented in the article. 1, prepare for what we can't imagine. May as well prepare for it. Who would have imagined COVID having the problems, us having the problems with COVID that we've been having? Put science first. That's really critical. Is that a lot of the problems with COVID is the misinformation that is out there, and I won't even bother getting into all the weeds on there, but there's lots of misinformation that's out there. We need to be science-driven with this thing and make our decisions based on the best evidence that science, in fact, will give us. Figure out who gets priority treatment. Again, a missed opportunity there. We had higher risk groups. We weren't absolutely sure initially. They were vulnerable. They got infected quickly, and unfortunately for many, it was very, very lethal, obviously, with those groups. Don't leave it up to the states. I know that there's this tendency to want to have the state do things, right? Oftentimes, and that's fine, but oftentimes the federal government is in the best position to ramp up vaccine production, to distribute vaccines and so forth, right? If you leave it up to the states, some states are going to go, we don't have a problem, and leave things wide open, and yet that virus is spreading there. People go in there, they take it to other states. It has been a mess. It has been a mess. And you can go back and Google that, and you'll see exactly what I'm talking about there. Stop the mixed messaging. That's got to stop. The people who are communicating the information must all be on the same page and not contradict themselves. I can't tell you how many times I've watched an evening lineup of shows on COVID-19, mostly commentary shows. One will say one thing at 7 o'clock, another one will say another thing at 8 o'clock, and people probably watching are going, what am I to believe? All right? We need a consistent message there. Stop with the fringe treatments. There are all kinds of treatments mentioned how to deal with COVID, none of them evidence-based. They were anecdotal or whatever it may be, but none of it evidence-based. We got to stop with that and go with what is scientifically sound. Another thing they mentioned in this article is let teenagers be teenagers. It's interesting because they're going to be a lower risk group, so maybe in terms of protecting the vulnerable in that, maybe we should have let teenagers, be back in school, these kinds of things. Hindsight's great, but nonetheless, they're saying we need to pay attention to this in terms of the next one. And then awareness of the origin of the virus and early intervention. Again, that's going to take a better, more robust surveillance system on the part of the World Health Organization. So now is the time for the World Health Organization to really get the support of countries to be able to do more. All right? And then finally, we can kind of wrap things up here saying we got a lot of information out there, and tech has been very much involved in this. We still have this slowing the spread of COVID-19. There's a little link there that will give you a couple of minute video on how they slow that spread. How we've operationalized it here at Virginia Tech. We have a helpline where anyone can call that helpline, ask a question, you'll wind up getting the answer to the question, a scientifically sound answer. And then we have many public health students, or what they call COVID crushers. They're downtown and they're spraying hands with the Purell and that, hand sanitizers, and they're wearing masks and they're giving masks out and so forth. So they're down there trying to do the best they can in terms of helping students, helping others downtown basically do what they need to do to prevent the spread. And so finally, most of us are optimistic that life will be back to normal in fall 2021. Again, we're optimistic about that. There's no 100% guarantee. And then the main uncertainties we have right now is how many will get vaccinated. You see, there's another concept that I really didn't talk much about called herd immunity that's really, really important with this any viral pandemic, epidemic. But nonetheless, how many are going to get vaccinated? And you hear more reports about groups not wanting to get vaccinated. They're worried about it, whatever it may be, and that's going to be a problem. And some of the variants with respect to COVID, okay, some of the variants are going to be potentially problematic. Maybe, maybe not. We don't know, okay? Only time will tell. So again, we streamlined a lot of this. We talk a lot more about it, but this is a typical kind of a lecture that you would get in a public health class, and supplemented with video and other kinds of activities, and even problems that we do in epidemiology and so forth. Okay, thank you.